Hello, everyone. Dr. Nikhil Verma here with another edition of Things I Didn't Learn in Med School. Today, I want to talk about the concept of how physicians are continuously using corticosteroids as their go-to treatment for general musculoskeletal injuries and disorders. It's very interesting because this has become the default, and it's become the default for so long that I don't think a lot of physicians are even questioning why they do it anymore and if it is the best practice. Let's talk about some of the reasons why it is the default as we are today in 2026. First off, corticosteroids are quick. They are done in the office, typically same day, usually done without any image guidance. And I would urge you, if you have a practitioner that's doing any injection in a musculoskeletal area, that they should be using visual guidance outside of some trigger points and maybe some more superficial structures. But even then, I would really like if they were using ultrasound or fluoroscopy guidance. It's quick. It's done in the office. Patients will get pretty immediate relief. Now, sometimes they'll have a flare-up from the steroids or the medication for a day or so, and then the medication, such as the steroids, will kick in after a few days. But when there's anesthetic agents in that injection, it can help alleviate the pain almost in real time for a lot of patients. It's billable, right? The insurance company actually will reimburse physicians for doing these injections. Part of the reasons why physicians don't use any visual guidance, ultrasound or fluoroscopy, is one, because you might need an extra authorization for that, or two, they don't have the training or the skill set to make that a quick and effective treatment option. The studies show that when we're using the visual guidance, such as ultrasound, we increase our accuracy to get the medication to that targeted site way more frequently. Another reason why is because it's easily accessible. Lots of physicians can have steroids in their office on the shelf for several months. And when a patient needs this treatment and they're coming to them for that treatment, it's easy to deploy. The insurance companies, they want this. They want patients to come in and get the injections done. But as we'll talk a little bit more throughout this video, is this the best thing that we're doing for our patients? It's part of the reason why I'm slowly moving away from doing corticosteroids in my office and moving more towards regenerative options such as PRP, platelet-rich plasma, bone marrow aspirate concentrate, or microfat lipoaspirate injections. Combining that with prolotherapy, things like MLS laser and shockwave, hyaluronic acid injections that have better evidence to protect the joint themselves. So I'm segueing into now talking about why these corticosteroids are a poor choice. If you review some of my old videos, as well as what I posted on LinkedIn last week and my Instagram, I talk about how there was a study that was published in 2025, the end of 2025, and how it was discussing using corticosteroids in knee arthritis for populations that were otherwise controlled. The individuals that had the steroid injections were significantly more likely to go on to a knee replacement than those individual patients without the corticosteroid injections, despite having the same degree of arthritis in the knee. So that goes to show what we've been saying is that these injections actually increase the damage of the joint, increase the pain in the long run, and increase your likelihood of going on to a joint replacement. Now, this was just for the knee. There's another study in about 2022 showing patients that got injections for tennis elbow, it's the outside part of the elbow here, they would go on and have less benefits from their physical therapy and potentially more damage than those individuals that just did physical therapy. So that again, that's another example. We've also shown and seen the destruction that steroids can do to other parts of the body, potentiation of making small deposits in the epidural space when we inject that there. That's a lower level study that's kind of been shown by a physician that was a spine surgeon. He noticed the patients that had the epidurals had these small deposits in their epidural space versus those that didn't. Again, this is a lower level study. We're not really sure where that's going to go, but that's another indication that we might be on to something that's saying that these steroids aren't our best choice or our best options. There are other studies that are ongoing of showing how injections into things like the Achilles tendon and the biceps tendon can actually increase your risk of rupture of those tendons. There's more and more data that's coming out how detrimental steroids are to the immunological system, the endocrine system, even at lower doses and single injections. So the idea of the whole video of us using steroid injections as our first line must be questioned. There is something to be said about using these medications and treatment options. Are we actually doing more harm than good in the long run? And I get it. Patients want immediate relief. Patients want to use their insurance. Physicians want to help their patients the best they can, as quickly as they can. But if we look at the grander scheme of things, are we doing the right thing? That's one big reason why my practice has moved away and continues to move away from corticosteroid injections and other destructive therapies such as ablations. So if you're a patient and you're going to your physician, I would encourage you to ask them, do they know these studies? Are these studies relevant to them? Are they paying attention to these studies? There are definitely situations where it's okay to use steroids, especially in short term, if that's absolutely needed for certain reasons. I can see an argument for that. If patients don't have the financial means to pay for some of these other treatment options, I can see a reason for that. But if you're really looking out for the longevity of your body and keeping your body as strong and as healthy as possible to avoid surgeries, to decrease the destruction of the joint, it's time to start having better conversations with our physicians. Some of the other low-hanging fruit that we can focus on are exercise and lifestyle modifications. We can definitely look at our diet. We can decrease smoking, alcohol use, drug use. We can consider supplements. Some supplements have some studies. Of course, they're not high-powered studies, but there are some studies out there that show supplementation can help with pain and arthritis. It may be better than some medications like steroids and non-steroidal anti-inflammatories. There are other options out there that we won't get into too much, but some at-home devices like red light therapy and TENS units and those kind of things that don't necessarily restore or fix the joint, but it can help decrease pain and inflammation. And at the end of the day, if this is something that you're more concerned about and you really want to take it to the next level and be like, what can I do to really protect my joint? That's when you go work with a practitioner who is specialized in regenerative medicine or orthobiologics. Now, practices can say they are specialized in this. It's easy just to slap on a sticker on your website. It's easy to tell your patients, et cetera, et cetera. What's not easy is to be an individual who reviews these research papers that are put out by their colleagues, that go to the conferences, maybe one or two a year, and makes connections and has discussions with the authors of some of these articles, but also see what the new technology is out there and see what other options we have for patients in the future. On top of that, at these conferences, more often than not, you learn new techniques. You learn ultrasound guided procedures, fluoroscopy or x-ray guided procedures. So you're continuing your education far beyond what was taught to you in medical school, residency, and fellowship. You're taking the onus on yourself to learn more and more and see how we can better help and treat our patients. And these are really, really in depth conferences. You learn so much, you take away 10x what you came in with. And for practitioners that have been doing this for several years, 5, 10 years for myself, learning from people that have been doing 20 plus years, 30 plus years, you really walk away with a suitcase full of knowledge that you can implement the next day to help your patients. And quite frequently, you go back to the conference and you'll learn the same body part anatomically that you've learned a million times in the past, but you relearn it and you rehone those skills and you refocus those skills. And that's what makes a practitioner so specialized and so well trained versus someone that's doing blind injections without any training, without injecting multiple structures, with just giving you an intra-articular or intratendinous injection without hitting the other structures that are involved, ligaments, tendons, muscles, tendon sheets, et cetera, et cetera. And if the practitioner that may not know the necessarily right spot and the right concoction to put these medications. We know that a lot of practices out there are not concentrating their platelets at a high enough level to produce an effective result for knee arthritis. So if they're not doing it for knee arthritis, how do we know we're doing it a well enough job for tendonitis or tendinopathy or ligament damage or other treatment options? For spine protocols, we know since we're injecting a lot of structures, we need a very, very high level of platelet concentration. So that's the concept I want to bring to everyone's eyes. And I really encourage you to go out to your physicians. And if they are giving you steroid injections every 3, 4, 6 months, 12 months, what have it, you should really have this discussion with them and ask them if they know the studies. And this isn't to put them on the spot, and it's not to throw physicians under the bus. There's just too much to learn out there. And the science and data is continuously evolving. But I think it's important for you and your health. And if that's something that's important to you, I recommend you giving me a follow. I have tons of content that I'm going to continuously put out on this topic. I put it on my Instagram, my LinkedIn accounts, Facebook, and my X account, my Twitter account. And if you want to work with a practitioner, I'm happy to help out. Or if you want me to help you find someone in your area, send me a message, send me a DM, and I'll gladly try to direct you to someone that can help you out. And as always, like, subscribe, follow, and if you have any questions, drop them below. We'll talk to you next time. Take care. Bye.